This is Module 5, Reconstruction and Post-Processing, Module 5B, Post-Processing Algorithms. In physical space, the separation between object A and object B is relatively simple to determine. However, when we are presented with images in image space, the separation between A and B is somewhat blurred by the characteristics of the edge that encompasses A and encompasses B. The separation between A and B, if we display the entire set of CT data within the full 2000 grayscale level representation, the actual edge between A and B, the true edge, is called the full width half maximum. That is the density absolutely between the maximum density in object A and the maximum density in object B. When we, however, present to our information in terms of displaying the images, we frequently do not display the entire range of CT numbers possible, but cone this down to a particular CT level and a particular viewing width or CT width. In this particular example, in the light blue, I have decided to display the images of object A and object B within a partial viewing width where I have truncated the total CT number representation. In this situation, then, the apparent edge between A and B is actually placed at this particular area, which is exactly halfway between my interpretation of the edge for A and the edge for B. This additional edge error then complicates my ability to make a true diagnosis because it does not define the edge of the lumen or the edge of adjacent materials such as non-calcified plaque, calcified plaque, lipid-rich plaque, etc. Thus, when the edge is misplaced in your visual interpretation, there are additional errors which can be created, such as false vessel diameter, false severity of stenosis, and the like. If one is to represent the true edge, this is visualized by placing the level at a value of the full width half maximum CT density, and the width of the viewing plane should be sufficient to include visualization of other structures of interest in the interpretation, such as calcium and non-calcified plaque. So within this particular blue area, I can clearly see that the separation between A and B still gives me a true identification of the true edge, even with a partial viewing width. Now, when we're presenting these information to our eye for interpretation, then the setting of window and level are very important in terms of our interpretation. Consider this reconstructed image of the aorta, the proximal left anterior descending, and the mid left anterior descending. You can see that there's a gap between the proximal and mid LAD. If this is the only image that I have to look at, I might hypothesize that this is 100% stenosis and that the opacification beyond the site of stenosis may be due to some collateral circulation. Now let's take the same image, reconstructed identically, but displayed on the workstation with a different window and level. In this image, you can see that the size of the proximal LAD is actually bigger than the apparent size on the image on the left. Furthermore, in this gap between the proximal and mid LAD, I can now see a very faint lumen and an area of plaque that may well represent dissection. So my differences in the interpretation are from 100% occlusion on the left to a subtotal occlusion with possibly some ulcerated plaque within the same region. Let's present the same image with this level and window. Yes, I can still see the characteristics, however, it is so bright that it's very difficult to interpret. And if you're going to try to display images with this very bright, broadened window, then you will easily get eye fatigue and not be able to continue your interpretation. Shown here on the lower left is a far better presentation of window and level, which displays the characteristics of the edges involving the proximal and mid-LAD. It clearly shows me that there's a subtotal occlusion, and I have a high concern for the possibility of an ulcerated plaque. The phase of presentation is also very important. You recall that we discussed CT phase reconstructions in previous lectures. Shown here are 10 separate phases reconstructed at 10 different sections during the cardiac cycle. 0%, 20%, 30%, and 40%. At 40%, this is end systole, and I can see the crispness of this right coronary artery very well. At 50% and 60%, there is image blurring, and returning again at 70%, which is end diastole or diastasis, I see an incredible ability to look at the image. Now, with just a simple difference between 70 and 80%, which means at a heart rate of 60 beats per minute or 1,000 milliseconds, this is a difference of only 100 milliseconds. I've gone from saying that the coronary artery at this section is normal at 70% to totally absent or occluded at 80%. Again, the fundamental importance is presenting the phase. I call this a beauty contest. If you're going to determine the best looking picture, you should have other images to review in order to determine that that particular image that you have in front of you actually represents the least motion within any particular imaging set. Here's another example. Here's an 80% phase reconstruction and an 85% phase reconstruction. The difference between the section on the left and the section on the right is no more than 50 milliseconds, and yet interpretation of the 80% phase is not possible, or interpretation of the 85% phase is possible. So it's important that any post-processing of the original X, Y, Z images does not result in enhancement of the data, but a loss of data. And the issue is to provide a technique that results in an acceptable clinical utility, or in this case, as an acceptable diagnostic, non-invasive coronary arteriogram. When we're presenting this data for evaluation, we take the images in individual tomographic slices and then are required to look at them at multiple views from multiple angles. So even though we have standard transaxial images shown on this slide, you need to understand how to reprocess them into orthogonal images in a transaxial view, a lateral or sagittal view, or in a frontal or coronal view. Manipulations of the images then, or the tools of the trade, require all of the following. Two-dimensional tools, which are planar projections that can be found in any plane. We use two-dimensional tools in the cath lab, in the magnetic resonance imaging laboratory, in the echocardiography laboratory, and in the nuclear medicine laboratory. We also have three-dimensional tools, and most importantly, four-dimensional tools. The fourth dimension being time or phase. You must then start to learn the language of 3D and 4D. Shown here is a shaded surface display, which is a three-dimensional display. This is called a volume rendering, which is also a three-dimensional display. Typical two-dimensional displays include thin slab maximum intensity projection, multiplanar reformations, and so-called thick MPRs, which are also called ray sum projections, and finally curved multiplanar reformations, or CPR. Each of these will be discussed in detail. Volume rendering technique, VRT, is a color or black and white display of the anatomy, preserving the 3D depth perception and the 4D cine or time capability. It is much more robust than a simple black and white image, as different densities can be coded at different colors. That provides a broader dynamic viewing range. It is, however, not adequate for definition of segmental plaque and stenoses. It is a wonderful display for publications, but is highly operator dependent. Manipulation of the images then in 2- and 3-dimensional space requires the ability to perform translation and rotation quickly and with high fidelity. You recall in previous lectures that the importance of 64 slice and higher multi-detector CT is that we can approach isentropic or cubic voxels. That means that any manipulation I make in 3-dimensional space, the actual dimension of movement is the same no matter which direction I look at. Thus, cubic voxels allow preservation and the potential for an isotropic display, which are essential to performing adequate CT cardiac imaging definition. Primary interpretive tools for plaque and stenosis assessment are usually 2-dimensional tools. There is the maximum intensity projection, MIP, the operator controls the thickness, and MPR, multiplanar reformation. This is a single voxel projection method. A thick MPR, or a ray sum, which is a thick projection method. The operator controls the thickness. And a CPR, or curved planar reformation. However, none provide true depth perception, and thus clinical interpretation must be done in combination with a volume rendering technique. A MIP, maximum intensity projection. This is a projection method which displays the maximum voxel density along any given ray perpendicular to the chosen plane. It can be thick or thin and is measured in millimeters. It carries no depth perception. It is still a major interpretive tool because of the robustness in application. It is still a planar 2D projection but has a 4D display capability. It often can be problematic when trying to assess a vessel with high-density calcium in the same plane, and it can be operator dependent. A multiplanar reformation, or an MPR, is a projection method which displays the true voxel density along any given ray perpendicular to the chosen plane. In this case, it is 1 voxel thick. It preserves source image densities. It carries no depth perception, is still a major interpretive and what I consider conformational tool. I use this as what I call the decision maker. It is still a planar 2D display method with 4D display capability. It is helpful in situations where calcium blooms in a thick maximum intensity projection. At 1 millimeter thickness, a MIP is nearly identical to an MPR, but because we have now sub-millimeter thick scans, they are not identical. It tends to be less operator dependent than a maximum intensity projection. A thick MPR, which is also known as a ray sum method, is a projection method which displays the averaged voxel density along a given ray perpendicular to the chosen plane. In many ways, this resembles a standard catheterization projection. It can be variable thickness, but average source density across these thicknesses. It carries no depth perception. It is still a major interpretive and confirmation tool. It is still a planar 2D display, but has 4D display capability. It's helpful again where calcium and stents bloom in a maximum intensity projection, and it appears to be less operator dependent than a maximum intensity projection. A curved multiplanar reformation is essential because the coronary arteries do not lie in a single anatomic plane, but curve in a 3-dimensional conformation. Thus, a CPR allows display of the entire vessel as if it lay in only a single XYZ plane. The CPR can be presented as a planar projection, as shown on the left panel, or as a straight line, or what I like to call a noodle view, in the image on the right. A CPR is a projection method which again displays the center line of the vessel as if it was in one plane. It is 1 voxel thick. The thickness is determined by the collimation on the scanner. It carries no clear depth perception. It is still a major interpretive and confirmation tool. It's a planar 2D projection but has 4D capability. It is very helpful in interpretation, and processing can be done without a decision as to the actual anatomic findings. So this allows one to pre-process the images by just finding the center line. That information then can be displayed to the physician for interpretation. It can be problematic in general for looking at branch arteries, and it is highly dependent upon the fidelity of the center line choice. As an example for a CPR, an individual user can define a seed point, which is defined in the middle of the opacified coronary artery, and then a path is defined at the center of the vessel or after the seed point is set in an interpretation called a region growing algorithm, which defines the path with similar CT densities. So if we have a curved vessel and put forward a particular seed point, then the CPR technique can display the entire vessel along a particular line, allowing us to look at it as if it were in a single plane. The problem is that the fidelity of the seed point placement can be erroneous, and in this particular setting made by the computer, the interpretation might suggest that there is a significant stenosis in the mid portion of this otherwise normal vessel. Now, one is able to go in and fix this by doing some post-processing, but errors generated when vessel diameter decreases and or other discontinuities occur can result in a variety of segmental problems with interpretation. Here's an example on the left of a CPR of the left anterior descending, and an example of the same vessel using a 5mm maximum intensity projection. You can see the vessel in both presentations, but the branch points and even a portion of the anterior cardiac vein can be seen clearly on the single MIP presentation, and they are not displayed on the single CPR presentation. The tools of the trade require that you use a variety of techniques. Here's an example of a thick maximum intensity projection. It has a particular thickness defined by those lines above and below the vessel. There also is a thin MIP, which allows one to thin down the difference between these two areas. So there's a difference between a 10mm and perhaps a 3mm MIP. Now, when we have the projection image with the thick MIP, we can see in this particular region that the maximum intensity within that cross-section is not lumen, but is calcium. So it displays only calcium. In the thin MIP, if I've included calcium as part of the imaging plane, I still see only calcium within that area. Thus, a MIP representation still displays the maximum intensity within the cross-section. Here is a thin MIP where I still have a very small amount of calcium, even a sliver of calcium, mostly lumen. The presentation, even a small area of calcium, can obscure my visualization of the vessel. If I thin this MIP down or move its altitude slightly, so I'm only looking at the lumen of the vessel and not the calcium, using a maximum intensity projection, I can see that the vessel is well displayed and that there is a generous lumen. So if no calcium is included in the MIP image, then vessel interpretation is imminently possible. Here again is a thin MIP, and careful placement of the MIP plane by adjusting the altitude of the slab can allow me to display the image to allow me to look at the subsequent lumen. In the same set of images, though, I could have performed an MPR, which is a single voxel thickness view, switching from a MIP to an MPR, and thus showing the same kind of view where I can see the lumen is quite sufficient. So a quick switch to an MPR provides the same solution as thinning and adjusting the height and altitude of the slab, which displays the maximum intensity projection. Another very important situation is to look at the vessel in a particular plane. Now this is just a cartoon, but the question would be, is that area of calcification in the middle of the vessel representing obstructive disease? One can then do a simple barrel roll or a 90-degree motion of that, and the plaque is then noted to be eccentric and non-obstructive. So with a simple movement or rotation about a particular axis, I'm able to use the benefits of having a cubic voxel to allow me to look for eccentricity of lesions. The convenience of a MIP does require that you carefully inspect the areas of potentially obstructive, hard, and non-calcified plaque. Again, the value of having cubic voxels and utilizing the full three-dimensional capabilities of the workstation cannot be overemphasized. Here again is another example of a thin MIP. The subsequent projection image shows only calcification. However, if I take that same MIP image and I perform a barrel roll by rotating about the center of the vessel, I can then produce this particular type of projection, which again shows the presence of eccentric plaque with a very widely patent lumen. So by doing the barrel roll, the eccentricity of the plaque and the calcium is revealed, and I'm able to assess the coronary lumen. Here's another example. This is a left anterior descending with a very bright area of calcium. Is this obstructive? By doing a simple barrel roll about this area, I can see easily that this becomes eccentric, non-obstructive plaque. Here's a multiplanar reformation. Remember, this is a single voxel through a particular area. This MPR can be rotated from a single plane, just like a maximum intensity projection, to also display eccentric, non-obstructive plaque. One also could have applied a thick MPR or a ray sum, which provides an average type density and also allows me to have the same capability to identify this as a eccentric, non-obstructive plaque. This is a summary then of the tools available for analysis. There are two-dimensional, three-dimensional, and four-dimensional tools, some of which can be displayed as thin sections, some of which can be displayed as thick sections. A volume rendering tool is strictly a 3D and 4D tool, which can be thin or thick. A maximum intensity projection is solely a two-dimensional display tool, which has 4D capabilities and can display thick as well as thin sections. A multiplanar reformation is a two-dimensional display and a four-dimensional display, but it displays only thin sections and cannot display thick sections. A curved multiplanar reformation, again, two-dimensional tool with four-dimensional capability, can display thin sections but cannot display thick sections.